Okay, perfect. So thank you so much for giving me the opportunity to present you those final results. They have been presented at ESMO. The paper has been published in the European Journal of Cancer, and it's really an honor to give you some conclusions and insights and certainly perspectives, especially in the field of quality of life, just what has been said a minute ago. So I'll be quick on those basics on desmoids, because I guess that everyone knows about the differences between somatic and germ cell mutations and the outcome of the disease. So let me switch to the real problem. The problem is the unmet need in progressing disease. Of course, we have a number of options, such as non-steroidal anti-inflammatory drugs, tamoxifen, low-dose chemo, either vinorelbine, methotrexate, vindazine, Calyx maybe, and the newcomers that are sorafenib or pazopanib. And there's only one phase 3 trial on sorafenib. Pazo was the Desmoid study, which was a French sarcoma group study, but it was only a phase 2. Of course, we have radiation therapy, and there's a general agreement that surgery has to be avoided as much as possible. Still, some surgery is performed mainly in Germany, as of I know. So definitely, we have a clear unmet need on patients progressing after all these treatments, and we don't have so many options outside of clinical trials, and we don't have so many clinical trials on new drugs, and some of these new drugs come from the US, but not yet approved in Europe as far as I know. So just a few words on cryoablation, which is the main purpose of this study. Cryoablation is an interventional radiology technique. This is something that has to deal with thermal ablation of tumors. It was initially developed in kidney cancers. Well, basically, patients are under general anesthesia, and the goal is to put those cryoprobes in a regular manner in the tumor. They are grossly separated by 1 centimeter. And when the probes are put in the tumor, this is performed with real-time guidance under CT or even better MRI. So this is the global picture of the patient with all the probes in the tumor, and you've got a control, and then in these probes you make circulate argon gas. And from physical reasons that I don't have time to explain, when liquid argon gas expands, the temperature really decreased to minus 40 degrees. So at the end of the day, you just have an ice ball at the extremity of the probe, and all these ice balls aggregate and make a huge ice ball that is supposed to cover the entire lesion. So you have this cryoablated zone where no cell can survive because of due to the ice, the membranes pops out and the cell dies. So this is really an interesting way and an interesting approach to desmoids. Still some difficulties because those tumors are solid as rock, and sometimes it's difficult to put the cryoprobes into that. So we had a few experiences from other centers, especially from the MSKCC, showing that that cryoablation was a promising technique in desmoids. But all these reports were retrospective, case reports, blah, blah, blah. So no prospective trial of cryoablation in DTs ever. So we aimed in Strasbourg to set up a phase 2 prospective study with the support of SOS Desmoid and the French National Cancer Institute. We were founded, and this was the story of the Cryodesmo 1 study. So we aimed to enroll adult patients with extra abdominal DT, no intra-abdominal mesenteric DTs, because it's too dangerous to perform cryoablation close to the mesenteric artery or to the bowel. All those patients were progressing after at least 2 lines of medical treatment, and the primary endpoint was non-progression rate at 12 months. Of course, we measured secondary endpoints such as pain, safety, and quality of life. A very interesting topic indeed. we had to include only patients in whom at least 90% of the tumor ablation was feasible, according to the expert radiologist advice. And the lesion has to be measurable with RECIST, and MRI was mandatory as well. So if we take a look on the results, we enrolled 50 patients with a mean age of 41 years old. Tumors were sometimes really big, with a medium tumor volume of more than 100 centimeter cube. We had tumors in the limbs, in the trunk, in the neck. And on the right side of the slide, you have the control rate at +1 year. So in the middle, you have the RECIST criteria. We had CRs, we had PRs, where stable disease. So the global clinical benefit was 85% success. Then we also aim to identify the success using the MRI contrast uptake, because when you destroy the desmoid, there is no vascularization. So the contrast product does not flash. And so this is probably the best way to analyze those desmoids. Definitely, you should undergo MRI with contrast products and subtraction sequences to show the effect of the treatments and to show where the tumor is even surviving or progressing. So basically, either by RECIST or MCU, a consistent, good rate of disease control at +1 year. Remember, in patients who were progressing under prior treatment lines, more than 2. So they had chemo, they had anti-angiogenics, they had tamoxifen, they had everything that was possible. So a good point. I'm trying to move. Okay, in terms of side effects, we know there's a spectrum of cryoablation side effects. Most of these are well known from prior studies. Pain in the early days, no more than 2 to 3 days. And this pain is generally managed in a hospital with narcotics, and it decreases quickly. Paresthesia, dysesthesia, neural impairment, this is a problem. And it is really related to the environment of the tumor. And as soon as the nerve is going below 15 degrees, there is some harmness. So this is something that the radiologist has to look at very, very closely. A few lesser side effects: musculoskeletal impairment, where the muscles are destroyed, but generally speaking, they are also destroyed by the tumor. Skin burn, if you're too close to the skin, and rhabdomyolysis, which was moderate. Well, taken together, all those side effects were manageable, and they all recovered within days or weeks. This is interesting because in parallel to the control rate at +1 year, we investigated quality of life. We investigated it using the EQ5D3L score that is basically designed for medical economic analysis, but still you can have some interesting values in there. And we measured that the global score did increase quickly after the cryoablation. As you can see, at +1 month, it's better, and it's very good at +2 months, and it remains stable and very good until 12 months. In parallel, when we looked at the subscales of the EQ5D3L, we found that anxiety and depression decreased over time. So there was really an increase in quality of life, and the daily activities also increased over time. So good results in terms of disease control, good results in terms of global quality of life scores, and anxiety, depressions, and activities. If we look at pain, as I mentioned, in the early days after cryo, you can have a small increase in pain because of the local swelling around the tumor, but this is rapidly recovering, and you can see that in all patients, pain quickly decreases, and most of the patients were able to quit painkillers in weeks. So on the upper side of the slide, you have pain as a severity score. This is just the intensity of pain. Just below, you've got the interference score. That means the interference between pain and daily activities. So you can see that the interference score is also decreasing in parallel, showing that as the pain is decreasing, daily activities increase, and subsequently the quality of life also increases. And on the right side of the slide, you can see that the painkillers consumption really decreases quickly at month 2 and is almost stable until the end of the follow-up. Just a few images to show you how it looks like. So on the left side, we've got this MRI with the heterogeneous desmoid. The big issue on desmoids when you go cryoablation is to adequately find the tumor limits, and because it's pretty much the same as planning a radiation treatment. You want to have the tumor volume and then the gross volume, because you don't want to miss a tiny extension of the tumor outside of the cryoablated zone. And the problem is that if you miss some of these extensions, the tumor may recur at this very place. So here you can see that the inside of the tumor of the cryoablated zone is completely free of MRI contrast product. This is the small zone that is in hypersignal. This is the absorption of the liquid, and this zone is going to vanish progressively over weeks or months, and symptoms quickly disappear, even though you still can feel a kind of gelatinous pouch at the place of the disease. Cryo can be performed in large tumors. This is an example of a young man with a huge cryo of the upper arm, and he underwent the procedure in April 2018. And you can see that more than 10 years after, it's still really great, because you've got this liquid gelatinous pouch, but it's slowly regressing. There is no suspect MRI product contrast intake around the tumor. So it's a complete response. Still, you can see that. So this is why the RECIST criteria are probably not appropriate for desmoids after cryoablation, and the MCU score is probably better. When it comes to progression, all the patients were not cured, but at this median follow-up of more than 3 years, the median PFS was not reached, but the curve is not plateauing. We looked at variables that would impact on progression-free, and the only one we found was tumor size. And this has a lot to do with the tumor volume that has to be treated. And in a few words, the bigger the tumor, the more difficult it is to ensure that the tumor will never recur. So there's a huge interest in moving cryoablation earlier in the disease, and perhaps to help in curing some of these tumors before they reach a size that makes them not fit for cryoablation. And this is just a picture to show you where the problem is. This was a huge desmoid of the hip, a young woman who wasn't able to walk or to put her trousers on, and she underwent cryoablation with a very, very good symptomatic effect. But you can see that a few months after, still this was really encouraging in the huge part of the tumor, but we also found those tiny hypersignal things around the tumor on the upper and lower part. These were probably tumor extensions that were not treated with cryo because of the size of the tumor. And definitely, this is a progression. You can see that the cryoablated zone remains tumor-free, but at the limits, you have the relapse. This patient is under medical treatment, and as far as I know, she's doing well in England. So just a final slide on what's coming. It should be coming this year, hopefully, because of COVID-19. This is a Cryodesmo 02. This will be a randomized study comparing in patients who are progressing after watchful waiting, cryoablation as frontline treatment to medical treatment at investigator's choice. And this medical treatment will be either vinorelbine or intravenous chemo, methotrexate, vinblastine in adults or children after 12. So we will compare cryoablation to medical treatment, and in case of progression, switch the two arms so all the patients will have access to cryoablation. We aim to enroll 150 patients, and we will investigate, of course, safety, efficacy, but also quality of life. And we will be looking to quality of life using the ePros. And we found items on the NCI ePros library that were identified as meaningful in desmoid tumors. These items were discussed with patients in the SOS Desmoid. And this is, I think, a very interesting way to investigate quality of life by giving the patients themselves the items to score in patients' wording, not in doctors' wordings. And I think it's easier to show a difference between arms directly from the patients with a tablet or iPad, Android, whatever. And I think it's also very interesting to investigate quality of life and to discuss the quality of life investigation with patients before to do the study. Last thing, in desmoids, investigating quality of life is a long story. This follow-up is going to last for more than 3 years. So, and this is why I asked this question, and Rose, because asking a questionnaire with more than 100 questions every 2 months for 3 years, but I don't think this is feasible. You will have too much missing data at the end of the curve. So this is really something that we have to discuss in common, and I'm very confident we will make some progress. Thank you.